Hello, welcome to the Let's Talk Kids Health Facebook Live Show, episode 35. I'm Dr. Narissa Bauer, your host. I'm a behavioral pediatrician and blogger of Let's Talk Kids Health. As you know, the concept of the show is to share information about behavioral health, parenting, and family wellness. Each week, I plan to bring you topics and guests to help me advance this mission so that we can all talk together. Now, let us know that you're here by posting comments and likes. The replay will be immediately available after the broadcast. Please share the episode with anyone you think who could benefit. Now, if you don't want to miss future episodes or maybe check out some of the past ones, please subscribe to my YouTube channel, Narissa Bauer, MD, and follow my blog Facebook page, Let's Talk Kids Health. Okay, so now on to this week's guest. Let's welcome Dr. Valeria Nanclares. Dr. Nanclares is a licensed clinical psychologist who has specialized in neurodevelopmental disorders with a strong emphasis on diagnosis and intervention of autism spectrum disorders. For over 25 years, she has been working with children and families in a variety of settings, from research to clinical practice. For 20 years, she developed and directed the autism treatment program at Advocate Children's Hospital in Chicago, Illinois. She translated into Spanish the gold standard instruments for the diagnosis of autism: the Autism Diagnostic Interview, Revised, and the Autism Diagnostic Observation Schedule, or the ADOS. She provides trainings throughout the U.S. and Latin America, helping professionals and organizations create greater access to services and improve care for children with autism spectrum disorder and their families. So impressive. Since 2018, she has remained as consultant for Advocate Children's Hospital and has joined the Echo Autism Hub team. She is now the Director of Program Development and Global Expansion for Echo Autism, helping to replicate Echo Autism clinics in Latin America. This is so exciting to have you here today. Thank you for joining the show.
Thank you for having me. I'm excited to be here.
Yeah, and this is such an important topic. And, given the work that you do, first of all, autism is so important to catch early. And access to services is so important. And that's why I am so excited to have you here, not just for the families who watch and listen to the show, but for the providers who also have been really struggling with how to do this and get kids hooked into services. They might not feel as comfortable doing this type of work. So we have an expert here on the show today.
Yes. And that's kind of the mission of Echo Autism, right?
Yes.
Is to really disseminate best practice guidelines to those that don't have the expertise to help them really with the process and kind of decentralize where the services can be found and
that's right.
Create greater access, right?
Yeah. So, just so that we can sort of make sure that we're all on the same page, maybe even before this, why is early identification so important? What about just the definition of autism spectrum disorders, and then why is early identification so important?
So autism spectrum disorder is a neurodevelopmental disorder. That means that something in the development of how the connections in the brain are formed from the get-go cause difficulties in terms of how somebody communicates, how they interact with others, and how they behave, right? So it's kind of this three-prong, social communication deficits, and then the restricted and repetitive interests and behaviors. Right now, the only way that we have to diagnose autism is behaviorally. It's by what we're able to observe. Mm-hmm. And this is why it's so important to use those standardized instruments that you mentioned before, the Autism Diagnostic Interview and the Autism Diagnostic Observation Schedule, because they do give us that standardized approach in terms of how to look at these different characteristics and look at the behaviors that kids are presenting and be able to figure out whether they meet those diagnostic criteria for an autism spectrum disorder. And it's a spectrum because it is very different, right? It varies widely between individuals and within the same individual over time. So it's a spectrum in both ways, right? It could be a spectrum in how much language a child acquires, how social or non-social a child is, how many of these difficult, rigid, repetitive behaviors they present. So it's complex in that you do have these kind of spectrums within the spectrum, but it's definitely called an autism spectrum disorder because really, truly, there are no two children that are exactly the same. And that's what makes it a little bit of a challenge. However, we do know that the diagnosis can be very stable by age 2. Right. And so there are these early markers that are really, really important that really have to do with kind of that early social emotional reciprocity. What does that mean? That's the give and take in a social interaction, right? What you're doing right now in terms of nodding your head when I'm saying something because you're understanding or you're agreeing with it. This is part of social emotional reciprocity, letting the other person know that you're understanding what they're saying and that you're participating in that interaction or in that conversation. And this happens from a very early age, even with babies showing their parents, for example, an airplane that went by and they're excited by it and they might point at it and vocalize and look back at the parent and check to see if they're looking too. That's social emotional reciprocity. So some of the early markers that we see with autism, even before age 1, have to do with those differences in terms of children not having those skills to be able to kind of reference and share attention and emotion with others. And so by age 2, we can really tell whether these things are just transitory, it might be for some other reason, or they're really more established. And getting that diagnosis early, going to the question that was posed, is really important because we know that the earlier the intervention, the better the outcome over time. And we're seeing that more and more now with these outcome studies, that look at those kids that did have early intervention. How did they fare over time in comparison to those that didn't receive that early intervention? And there's a huge difference, both behaviorally and neurobiologically.
Yeah. And, I mean, as a pediatrician myself, thinking about what tools we have at our disposal, because I know a lot of the pediatricians, their visits are brief, 15, 30 minutes. They have the luxury, though, of seeing those families over time, which is really great. However, that time, that visit and that high output of patients they have to see make it challenging for pediatricians to be able to really spot that. So, using validated instruments is really important. I guess for people who are watching who are parents, who would they talk to first? I mean, obviously the pediatrician, and you mentioned several gold standard instruments. Who do they go to for that?
So, I mean, I think right now it's, autism centers or specialized centers, right? So I was part of the Pediatric Developmental Center, and so it's a center that specializes in children who have developmental differences. This is a trick, though, because we know that, it's a kind of a bottleneck, and, then there tend to be long wait lists. So, I think more and more the thought is to really have the pediatricians equipped to be able to, those cases that are a little bit more unambiguous, meaning that we don't need to refer them. We want to get them started with services to try to really catch them in the pediatrician's office. And so there's, screening tools like you have the MCHAT, the modified checklist for autism in toddlers, that is a screening. It's not a diagnostic test, but it does give you a lot of information. And so by obtaining some knowledge with that and something like another screener like this, the STAT, the screening tool for autism in toddlers and young children, these are things that pediatricians can incorporate into their pediatric offices, and can help them really start teasing things apart. There are going to be kids that they're going to have to refer on to a specialist, and those are usually either developmental and behavioral pediatricians, such as yourself, that have the training and the background for that, or psychologists in general who are specialized in neurodevelopmental challenges or differences.
I mean, we talked about the importance of early identification. What does the research show in terms of how early can you get, does it vary state by state, or, what are we aiming for?
We're aiming for, before age 2, right? Like you really, I mean, the point is to really catch as quickly as possible. And like I said, there's a lot of research that, has really looked at what point is the diagnosis very stable. And we know that it's very stable by age 2. So if you have a diagnosis prior to that, the likelihood of it being, an autism spectrum disorder is very, very high. I've had children referred to me as young as 12 months that have had, very significant differences in terms of their interaction, or who have lost skills, right? We know that about a third of kids with autism have this kind of profile where they seem to be developing okay, and somewhere between like 16, 18, 20, 24 months, there's a regression. And so obviously when there's a loss of skills like that, the parents notice right away that there's something different, and kind of seek some answers for that.
That's right.
But the sooner the better, right? And we do have, every state has the early intervention program. It's a federal program for birth to 3 that provides services for any child that has any developmental difference, right? Whether that's motor or speech, or something a little bit more complex like an autism spectrum disorder.
Right. Well, so that's a great transition to the next question, which is, what role do parents have in both the diagnostic and the intervention process?
I think they play a pivotal role, right? Parents are the ones who really know their kids best. And so a lot of the information that I, as a specialist, will gather is what the parents are seeing, not when the child is with me in the office, which is an atypical environment for the child, but it's more what they see in the day-to-day, what they see when they're at home, when they go out to the supermarket, when they're doing their daily living activities with family, friends, or at home. What are the things that they notice that are not working well, or things that they feel that are going well, but they're maybe a little bit different, right? And so it's really the information that they can provide is not information that I can see in the office per se, and so it's crucial. So having a good interview as a clinician, where you really review the symptomatology and the presence of symptoms, the generalization of those, difficulties. Do they happen only in one environment, or are they happening in multiple environments? Because that helps us understand what's happening overall with the development. And then certainly in terms of intervention, I think without the parents, we don't have intervention. The parents need to be an integral part, active collaborators, and an integral part of that treatment team. Again, it really doesn't matter what the child can do with me 1 to 5 times a week, right? It's what the child can do in their day-to-day activities with their parents, with their family, in their school environment. So really for the parents to understand and learn what are the strategies that work best for their child, it's helping them become really competent parents for this particular child that might need a different way of parenting, and supporting the child's development and growth, right? And so for me, the role of the parent is the most important one, because it's the one that helps us as clinicians make sure that we're providing the best care for that child.
Right. I mean, before we leave the diagnostic part of this discussion, what does a typical diagnostic session look like? Is it an hour? Is it with one person? What does that look like typically?
It kind of depends a little bit, right? But it's more than an hour usually, right? Usually there's the diagnostic interview that ends up being somewhere between like an hour and an hour and a half, where you're really gathering a lot of information, and reviewing any prior information or any prior reports that might have been from the pediatrician, or if they've already been to some sort of early intervention program where they've been seen by someone. So it's really gathering information. And then it's really kind of a direct observation of the child. And that happens either with the STAT or with the ADAS, these standardized behavioral observations, so that we can really look at those areas of social communication and behaviors, how they present themselves. So For the child, it seems very play-based, but we're deliberately doing things to see what the response is and measuring that response in comparison to what we would expect a child that age to be doing in this particular setting. So usually you have that diagnostic interview, and then you have a standardized observation, the direct observation. Sometimes, in Chicago, I was very lucky to work within a multidisciplinary team environment. So if the child was young, we would have a combined speech and occupational therapy evaluation at the same time. And so they would see the family together and really look at those communication skills and motor and sensory skills to see if any one of those differences could help explain better what was happening with the child's development, or was it all kind of part of this package that we call autism spectrum disorder.
Right. Now, I have one more question kind of related, because, we talked about how obviously early identification is so important before age 2. I'm sure, given the work that you do and the expertise you have, you've encountered kids who are diagnosed late. I mean, like, how late is too late, and what does that diagnostic process look like?
It's never too late, right? It's never too late, because there's always things that we can do. There are so many times where I'm evaluating a child, and the parent says, you know what, they look a lot like me. And then they seek an assessment for themselves as adults, right? Because they realize that maybe, it might look different in their child, but they themselves seek answers for things that have been difficult for them over the years that they've never had answers to. And getting that diagnosis, even as an adult, if it's the right diagnosis, helps you understand yourself and understand what sort of strategies you can put in place for yourself. So it's never too late, right? Obviously, for the children who are much more affected, the longer we wait, the more impact it has, kind of on your developmental landscape in general, right? One experience feeds another experience that feeds another experience. So if all of your experiences with your environment are that of autism, it kind of develops a landscape that is more of autism. And so we want to limit the impact that the autism is having over the development, and be able to support the development in a way that it is not so impacted by those kind of negative experiences, in a way, or the lack of experiences that the autism brings on.
Right.
So it's never too late, but obviously the sooner the better. And the research has supported that those children that do get the right services early on tend to have more enhanced outcomes over time in terms of their social communication skills, cognitive skills, language abilities, less ability to handle nuance in different situations, and become a little bit more flexible. Our world is difficult for people on the spectrum, because it's ever changing. It's not predictable. It's full of surprises, full of experiences that are difficult to navigate. And so the more skills they have in trying to navigate those, the less it's going to become, a negative experience for them, and something that might eventually cause more things like some of the comorbidities, right? Like anxiety or depression that sometimes we see in the older adolescents and adults, because they don't know how to handle all of these experiences well.
So, I think what you just said is, obviously, if you ever have concern, it's never too late to get the diagnostic process going.
That's
and
right.
Just like you said, I mean, the earlier obviously is better. However, it's, again, you need to help any individual where they are.
Exactly.
Right.
Exactly. Yeah. It's never too late. I would never say, don't, if there is a concern, seek out, start with your pediatrician, and if not, there are some great resources like Autism Speaks, for example, on their website, or even Echo Autism on their website has, a number of different resources in terms of which providers you can go to, or how to seek it Some of the American Academy of Pediatrics also has, by zip code that you can look for resources and specialists that are closest to you.
Mm-hmm. So, what are some of the evidence-based interventions? So we talked about the diagnostic process. Once there is that known diagnosis, then what? Like what can families expect? What does it look like?
Yeah, and I think there's, the blessing and the curse of Dr. Google, right?
Mm-hmm.
I think parents tend to very quickly, and all of us do, for a variety of things every day. We jump on the internet and we try to find answers. And unfortunately, there's a lot of misinformation about what are the best interventions for children and for people with autism. And so it is very important that the resource that you look into is a trusted resource. So sticking with large organizations like the AAP, the American Academy of Pediatrics, the CDC has very good resources. Autism Speaks has very good resources. So the ASAT Online, which is the Association for Science and Autism Treatment. These are sources, trusted sources, that only look at evidence-based practices, right? Mm-hmm. So for each child, it will be a little bit different. For each individual, it'll be a little bit different because what they need will be a little bit different. And this is where there's no cookie cutter approach, right? So kind of the gold standard in starting to look at is behavioral. Right, so we start with behavioral interventions, and those that are based on the principles of applied behavior analysis mm-hmm. are the ones that have the most evidence behind them. So things like Early Start Denver model and pivotal response training. These are based on the principles of applied behavior analysis. And what that means is that we're taking certain behaviors and we're breaking them down into small chunks and teaching them one by one to build those skills that didn't naturally develop in the child, whether that's communication, whether that's ability to attend to another, whether that's ability to follow instruction. All of these skills are skills that depending on how impacted the child is, will need more or less attention, right? Mm-hmm. And with that, then there are other approaches like the Picture Exchange Communication System, PECS for short, mm-hmm. To build communication skills that is based on an area of strength that many individuals with autism have, which is their visual learning. And so it's a way of learning what communication is all about via pictures. Mm-hmm. That's not to say that they don't develop language. In fact, the majority do develop language. 75% of those kids that start with picture exchange communication system will then learn to verbalize because they can visualize the language. Huh. And so it's a way of enhancing communication, not getting in the way of verbal learning. Right? So I think that's a big misconception sometimes.
Yeah, no, thanks for bringing that up because I'm actually quite surprised at 75%. And so a lot of parents think, gosh, if I teach sign or if I use pictures, is that going to replace or substitute in for spoken? But you're saying it doesn't.
It doesn't, because it's representational, right? Mm-hmm. If you think of what language is, it's probably the most abstract thing we do every day. We have these string of sounds that we've attached meaning to, mm-hmm. Right? And so we call this a headset. Why do we call it a headset? It's social norm, social convention, but there's no other, reason that this string of sounds means this, right? Mm-hmm. Other than the meaning that we've attached to it. And so this is very difficult for individuals on the spectrum because one of their areas of deficit is abstract thinking abilities. So this is why oftentimes language is delayed because they really don't understand language. And so PECS serves as kind of a bridge between the concrete object and the very abstract label, verbal label. Mm-hmm. And it's kind of a bridge between the two because it is a representational system, but using a system that they can understand, which is visual and manipulative.
Got it. Yeah. So a comment from Dr. Jess. She says, this is really good to know. So thank you, Dr. Jess, for commenting and letting us know you're here. Yeah, so I guess the other question is around like, how many hours or what does it even look like? Can this be delivered at home? Like, do the parents need extra support? I mean, because there's so much that goes into this. I can only
Yeah,
imagine what you're talking about
yeah.
with ABA, it's for with the child.
It is with the child, but I would
Hmm.
say that equally with the parent, right? I
Hmm.
think the big mistake is not involving the parent. And I think that's where ABA got a little bit of a bad rep for some time because it has been so directly associated with just working with a child and not working with a parent. And part of again, kind of part of this neuropsych profile for individuals on the spectrum is that they're very person specific and context specific in their learning, right? Because they are more concrete. So if they learn something with me in the office, it may not generalize to the
Right.
home unless we make it a goal to generalize it. And that
Yeah.
has to be with a family, right?
Hmm.
And so, the program I developed in Chicago was 100% started with a parent. It is parent training first, so
Hmm.
that parents become equally competent and understand what all of these principles of applied behavior analysis mean
Hmm.
and how to incorporate them in the day to day.
Hmm.
So, my job is for the parent not to need me, right?
Yeah.
For the parent to really know how to incorporate these strategies into the day to day.
Hmm.
So, it's really not about hours, right? Because it's about incorporating in any interaction successful strategies. And if you do that, you don't need hour upon hour upon hour of therapy, right? What you need initially maybe is a little bit more of an intense load. And like the program that I developed in Chicago, we were only doing about 3.5 hours a week of therapist time,
Hmm.
right?
Hmm.
So it's not the 20, 30, 40 hours a week. And we were very successful. This was published, comparing our results with the intensive behavioral intervention programs. And the key is the parent. The key is the parent learning those strategies so they incorporate it into the day to day, and they are part of the therapy. We never provide therapy without the parent present. The
Yeah.
parent should be present, unless you're working with a teen where it's not appropriate at times, or
Hmm.
you're working on separation, right? Or something where the goal is different. But if not, the parent should always participate, should be an active collaborator, and should learn alongside what are the strategies that are best and most successful for my child.
Yeah.
And once they do that, every interaction is therapy,
Hmm.
right? And
Hmm.
so then you see a lot of that generalization because they will use that same strategy at home, at the supermarket, when they go to a family member's house, when they go out somewhere. Those strategies will be incorporated because they will become second nature, right?
Hmm.
So it's really not quantity, it's quality. It's what you're doing, and then how is that being translated into day-to-day
Hmm.
activities. That's what makes all the difference.
Yeah, and I can see how with this model where you start with the parent and you're really tailoring it to the family, how it's very driven by the needs of that particular child. So it can look very different.
Very different,
Yeah.
very different. And part of it is really just finding, like the first part really needs to be figuring out what does this child need, or what does this individual need,
Hmm.
right? And that'll take a little bit of trial and error, trying to figure out, what are the best strategies. And it'll be trial and error with the parent, because you're going to try something and then the parent's going to take it home and then report back,
Right.
right? And until we find that right rhythm for that family, and each family is different, right? Like how much
Hmm.
each family can handle.
Hmm.
So maybe what the child needs is a whole lot, but what can the family handle right now? Well, let's
Hmm.
start here. Let's make sure
Hmm.
that they're successful at doing that, and let's build on successes and not continuous frustration, right?
Yeah.
um, because these are kids that most likely will have different types of needs for a long time. And
Hmm.
so we want the parent to feel successful at what they're doing and not burn out from, trying a lot of things that they feel surpass them, right? That they can't, or that they need someone like me to do it. They really don't. All parents are equipped to be able to help their child. It's, working with someone who's willing to take the time to really work with you, and like I said, help you become that really competent parent for that child. That should be the goal of the therapy.
Yeah. Yeah, no, I think this is great. And, for those families who, struggle with particular challenges that come up, you can pivot and really work on those, like
Absolutely.
aggression or
Hmm.
toileting or,
Hmm.
those types of things as well.
Yeah. And
Um,
oftentimes that's where you need to start, right?
mhm,
I mean, we
mhm,
want independence. And so they need to be toilet trained. Every child can become toilet trained.
mhm,
Some will learn right away, some will take years maybe.
mhm.
But it can be done. And every child needs to be able to have that self care because that directly impacts your ability to live an independent life later on.
Right.
And so does aggression, right? As soon as there's any little aggression, that needs to be addressed right away because we
Mhm.
don't want the child, maybe the child is 3 and it's not a big issue right now, but the child will become 12, 15, 20, and it will be a huge issue,
Right.
right? So we don't want any of that. So absolutely, sometimes your priorities need to shift depending on what's happening or what the response is.
Now, I know that we're at about 30 minutes and there are some people still watching. So if you have any questions, comments, please do ask. I want to pivot just for a few more minutes because I have you here. And given
That's
the
right.
work you do, training other people to recognize autism, I want to spend a little bit more time on that. And particularly looking and just asking you, does autism present differently or is it harder to detect across different cultures? That along those lines, because I know you're doing global
Yeah.
work in this
Yeah.
area.
And that's a great question. And I would say yes and no. There are certain
Hmm.
things that are very specific to those kind of social emotional reciprocity issues that I was alluding to before. That's cross cultural. Every culture has a way that a child tries to interact with their parent or with those around them to
Hmm.
gain attention and to share attention and emotion, right? And that's if that's altered in the way that is usually happening within that culture, it's altered, right? It doesn't matter what the cultural differences are.
Right.
There's a difference in terms of how that's presenting itself, right? And so oftentimes the question of eye contact comes up, right? Because eye contact does vary significantly across cultures. But it's really not about amount of eye contact. I think that the biggest myth in autism is thinking of this as lack of eye contact. It's really how is the eye contact used to regulate the interaction? And that
Hmm.
already has a cultural bent to it, right? And so if it differs from how culturally this child experiences eye contact, then you have a difference, right? So it's not a question of quantity, it's a question of qualitatively, how does this child or individual use their eye contact to begin, maintain, or terminate an interaction because every culture has
I
a
see.
threshold by which they use gaze to be able to do that.
Yeah.
So there are cultural differences, but within the culture, you can also tell where does it begin to slip away from what's expected for
Hmm.
that culture.
Hmm. So thank you for that. I have a question from Dr. Kelly Slama McManus, although I know it comes up as Jason. Thank you, Kelly. So how do you suggest for a provider handling a family that is not open to the diagnosis of autism? Do you believe the diagnosis is correct? Do not believe the diagnosis is correct or refuse selective therapy? Should we keep bringing it up, be patient, wait? Like any tips for that?
That's a fantastic question. And I think, you can't force the diagnosis on someone, right? And I
Mhm.
often tell parents, it's not my job to convince you that your child has a developmental difference. It's my job to help you understand what that developmental difference is.
Mhm.
So if they're not willing to accept the diagnosis, yet they're willing to see that there is a difference of some sort, maybe start there. Start with that difference and start getting the child, the right services so that we don't delay something just because we're waiting for the big kahuna, right?
Mhm.
The final diagnosis. So if they're willing to accept, for example, oftentimes they're willing to accept that there's a difference in language, and so let's start there. Meet them where they're at and help them start seeing how it's not just language. And over time, working with them. If it's a provider, a pediatrician, or someone who has the benefit of seeing the family over time, seeing that child more regularly instead of just the regularly scheduled visits,
Yep.
seeing them more often so that you can continue to monitor and continue to mention where some of those differences are. But you can't force the diagnosis upon someone, but you can definitely help them understand where the child's behaviors or development are not meeting the standards or are getting in the way of their functioning, right? Getting in their way of their ability to socialize with kids in preschool or in kindergarten, or the family's ability to see other family members because the child has so many meltdowns that they can't take them. And so they begin to get isolated a bit from their families, helping them understand other things and not pinning it just on the diagnosis per se, but what are the areas that are really interfering with your child and your family that maybe we can start there and then move them forward.
Yeah. I mean, and that, I think, as you said, I mean, meeting them where they are, and starting with that little, that little area. And again, I like how you phrase that, at least being able to get them to accept a difference, and then at least hooking them into intervention for that, and
Right.
going maybe in baby steps, right?
Exactly.
Yeah.
So whatever, if they're under the age of 3, getting them involved with the early intervention services is key. And all of this, you do have this provided by the state. It's something that all families can access.
Mhm.
And it's just a crucial window of development that we really want to take advantage of, because it's when the brain is super malleable. It's a sponge. It's absorbing all of that. And so we want to take advantage of that to get the most out of those early years.
Yeah. I will just kind of ask another question. And again, I hope this is okay. But in terms of, in my clinical practice, I see a lot of kids with anxiety, sensory issues, parents raise the question or been told, I don't know if there's also on the autism spectrum. I mean, how do you recommend going through and sussing all that out?
Yeah.
Because
And
it's
usually,
difficult.
and it is difficult. It
Mhm.
is difficult. And especially for those kids who do have kind of early sensory differences because
Yes.
they are so wary of their environment. But usually, with kind of those sensory differences, you can also start seeing what are the moments of comfort and what are the moments of discomfort, right? And if it's very specific to a particular sensory experience, whether it's touch or smell or sight, um, you can parse that out. If their social experiences are not altered at other times, then it's likely more sensory based than it is autism or spectrum based,
Mhm.
right? For an autism spectrum disorder, the primary deficit really is that kind of social interaction piece, that social communication, those deficits in social communication. And so those will be there regardless of the sensory experiences, right? The
Mhm.
same with autism. I'm sorry,
Anxiety.
anxiety.
Mhm.
Anxiety tends to be, a little bit more specific to certain environments or certain people or certain situations, right? Um, and so that's not necessarily the case in ASD, where we're seeing that those differences happen. It's pervasive. It's in all environments that you see some of these differences. Certainly, they often feel much more comfortable at home, right? So there will be differences between how the child behaves at home and with their caregivers than others outside of the home. But that anxiety piece for kids who do not have a spectrum diagnosis tends to be really tied to something a little bit more specific, and you can really parse that out, right?
Mhm. Mhm.
So that's, obviously an oversimplification, but this is, and it's not to say that we can't have, an autism spectrum disorder and anxiety, because we
Yes.
often do see that,
Yep.
right? Or an autism spectrum disorder and sensory differences, because we know it's one of our diagnostic criteria is if there are sensory seeking behaviors that are atypical in
Mhm.
nature,
Mhm.
like trying to look at things at different angles or sniffing, licking, rubbing of textures. That is one of the diagnostic criteria.
Mhm. And then the last question is about echo itself. Like what, I mean, we've used this term and I want just people who are watching to understand what that is. What does that mean? Echo autism.
So ECHO is actually an acronym, right? So Extension for Community Healthcare Outcomes is ECHO.
Mm-hmm.
And in Project ECHO did not start in the autism field at all. It started with liver specialists and hepatitis C, with the intent of getting knowledge closer to patients instead of patients always needing to travel to knowledge. So working via kind of a hub and spoke model, the hub being a team of specialists, the spokes being other professionals that are in rural areas or underserved areas or areas where there are scarce resources for specialists, really help them to be able to help their own community so that patients don't always need to travel. So Echo Autism is about that. It's a bringing best practice guidelines and care, longitudinal care and management of comorbidities like we were talking about, like anxiety, depression, ADHD, feeding issues, sleep issues, all the things that come along with ASD. It's helping primary care physicians, psychologists, nurse practitioners, those that are in those primary settings that first see these kids to really be able to do that early detection and immediate care within their communities without needing to always refer to a specialist. In some cases, there's no choice because it's a little bit more complex, right? But at least they can do that first triage and really be able to support their patients in their communities and be the point person, the reference person.
Yeah. And so right before we went live, you were mentioning that tomorrow you're going to be doing an echo training.
Tomorrow, actually, an ADOS training.
Oh, an ADOS
right?
training.
So, yep. So it's 3 days. Tomorrow, Saturday and Sunday, all day, for a group of about 30 psychologists and pediatricians in Mexico.
Wow.
So helping them learn best practice and identification. So learning this tool, which is the ADOS, but we talk about much more than ADOS. It's really about what does an evaluation look like? What do you need to look for? How do you think about this clinically and incorporate an instrument like this in your clinical judgment? How do you develop that so that you provide the best care for your patients?
Yeah, that's so fantastic. I mean, for you to be able to bring your knowledge out there and support the training of these folks who, as you said, are going to be needing that skill set to be able to make those early identification in their communities. It's really wonderful, the work that you do.
Exactly. It's the amplification, right? So instead of me working directly with one person, with one family, it's really helping the professionals who then have an amplification effect in their community. And that's really what ECHO and Echo Autism is all about, is really that amplification of resources so that we can increase best practice care for any child or any individual that needs it.
Yeah. Well, so I'm just as we're wrapping up, I think we talked a lot about different resources out there. I know you mentioned Autism Speaks. I'm going to throw up echoautism.org. Can you just mention like what people will find when they go to that website?
So echoautism.org has an enormous amount of resources for parents and professionals in terms of toolkits, sleep, feeding, ADHD, anxiety, diagnosis, early detection tools, how-tos of a variety of dentist's office, how to take your child to the dentist's office and have that be a successful experience. So a lot of these toolkits that have been developed over the years, and Autism Speaks has developed a lot of these. So Autism Speaks also has an enormous amount of toolkits in a variety of different languages that have been translated. So there's resources in a variety of different languages that have all of these different toolkits and resources, both for parents and for professionals.
And that's all free.
It's all free.
Wow.
All free.
Yeah.
All free.
Okay. Well, people go there. And then if folks want to reach out to you professionally, I think we were talking about you have a LinkedIn profile.
Feel free to reach out to me. Just mention that you heard on this talk, so I have some context for it. But absolutely, feel free to reach out to me there, and I'm happy to respond.
Thank you so much. I mean, this was such a great conversation. There's so many things here for both families and providers, pediatric specialists, just to understand the importance of early identification treatment, where they can go if they want some more training, and the importance of evidence-based practice and intervention. So thank you so much for this great conversation.
You're welcome. My pleasure.
Yeah. And so for those of you watching, as you know, I have a show every week. So my next week's special guest is my dear friend, Dr. Jennifer Katzenstein, who's going to be coming on the show to discuss adolescent mood, COVID, and suicide. So you won't want to miss that. As well, it's the month of September. It's never too late to join my free book club. And this month's book club pick is Conscious Parenting by Dr. Robert Saul, a pediatrician. And he has graciously agreed to do a book chat Facebook Live with me in my parenting discussion group. So you don't want to miss that. Plus, this book is only 76 pages. So it's not that much to read. And it's a really great read. So I think for those of you who join, please just check that out on my Facebook page, and you can still sign up and join the conversation. All right. Well, thanks again. And if anybody watching, if you have any topics or guests that you'd like to suggest, please don't hesitate to email me at drnarissa@letstalkkidshealth.org. Or just drop a comment or reach out to me on any of the social media platforms, because I'm everywhere. And until then, that's it for now, and we'll keep talking.